Perfect. Excellent. I hope all of you are preparing well, and I hope you all are ready for the exam. The last few days before I start the session, I just want to say the last few days focus on the previous year question papers, on the December 2021 paper and the June paper prior to that, because those are the papers from which repeat questions or repeat topics are asked frequently. Okay, so I've also shared the link for the December recall. It's there on my YouTube channel. You can watch that. That would also be very beneficial. Now, without wasting any time, because we have a lot to cover, let's start quickly. We are going to do the important potential questions which can be asked in the exam. And also these topics are the ones which you should revise from surgery in the last few days. Okay. Surgery is a major topic. Last time also there were close to 30 to 35 questions from surgery. If you have any queries regarding the session or any doubts, this is my Instagram ID, left-handed surgeon. You can always contact me there. Can all of you hear me before I start, please? Just give me a thumbs up if you can hear me, please. Perfect. Yes. Okay. So cannulas are asked every time. IV lines are asked every time. Quickly answer this question, please. Cannulas are asked every time. Correct. Green color cannula. Green is 18 gauge. 18 gauge is the correct answer. Excellent, guys. Excellent, everyone. Green is 18 gauge. This color coding you need to remember for the exam. You need to remember the color coding for the exam. It has been asked multiple times. It has been asked multiple times. Now, one question which is being asked in the PG exam since the last 2-3 years, and whatever is being asked in the PG exam then gets asked in your FMGE exam as well. So you should know the flow rates as well. So orange has the highest flow rate, 240 milliliters per minute. Then you have gray, which is 180 milliliters per minute. Green is 18 gauge, 90 milliliters per minute. And pink is 60 milliliters per minute, right? So these are the four which I want you to remember for the exam. These flow rates also you should remember. You can see that larger the cannula, wider the cannula, more will be the flow rate. Okay. Now, the most common complication of IV lines, this has also been asked in your exam. This is superficial thrombophlebitis. Superficial thrombophlebitis is the most common complication of IV lines, which you should know about. Another question which has been asked in the exam, while inserting the cannula, while inserting a central line, the patient becomes breathless and there is absent breath sounds. Absent breath sounds on the right side. What is the most likely cause? Most likely cause, everyone? Correct. Most likely cause is pneumothorax. Very good, pneumothorax. And that is why we should get an X-ray done whenever we are inserting a central line. We should always get an X-ray done as well. Now, the most common vein where a central line is used is IJV. This has been asked in the exam, internal jugular vein. And the least infection is with subclavian, right? Least infection rate is with subclavian, but subclavian has maximum pneumothorax rate. Subclavian will have maximum pneumothorax rate, okay? This is a PICC line, peripherally inserted central catheter, where you insert it like a cannula, but the tip lies like a central line. The tip is going to lie like a central line. Best method to check the correct placement of a central venous catheter. How do we check the correct placement of a central venous catheter? Correct. X-ray is the correct answer. Chest X-ray is the correct answer, and it should lie at the junction of, where should it lie? At the junction of SVC, superior vena cava, with right atrium. So the junction of superior vena cava and right atrium, that is where it should lie. That is the correct position of the central line. This also you should know for your exam. Surgical positions are invariably asked. One question from surgical positions is asked. Which surgical position have I shown here? Correct. This is the Fowler's position. Very good. What is the risk of the Fowler's position? What is the risk in Fowler's position? It is used for CNS surgery, central nervous system surgery, posterior fossa. Very good. That is correct. What is the risk? Excellent, guys. Excellent. It is the risk of air embolism, increased risk of air embolism. Very good. These are the other surgical positions. You know, this is supine position. This is lithotomy position. Which nerve can be injured in the lithotomy position? Which nerve can be injured in the lithotomy position? Common peroneal. That is correct. Common peroneal nerve. No, common peroneal nerve. Not lateral cutaneous, common peroneal nerve. Very good. This is the lateral of the kidney position. This one is the prone position. This one is the prone position, which is used for spinal surgery. This is the prone position, which is used for spinal surgery. Okay. And this is the jackknife position. This is the jackknife position, which we don't use now. Why don't we use the jackknife position? Why don't we use the, very good, excellent, positional asphyxia? Because of positional asphyxia. Excellent. Good. One question from sutures is also definitely asked. Sutures, definitely one question will be asked. Which of one of the following? It is positional asphyxia and not traumatic asphyxia. It is positional asphyxia, please. Which one of the following is not an absorbable suture? Not an absorbable suture. So polyglactin is vicryl. Polyglactin is vicryl. Polypropylene is proline. Polyglycoperon is monocryl. And polydioxone is PDS. And out of these, proline is non-absorbable. Others are absorbable sutures. Others are absorbable sutures. Correct. So this is regarding absorbable and non-absorbable sutures. This is regarding absorbable and non-absorbable sutures. Natural sutures. Natural sutures can be catgut, right? Catgut can be a natural suture. This is natural absorbable suture, which is from sheath submucosa, and it undergoes enzymatic degradation. Synthetic absorbable are monocryl. This is used for monofilament. This is a monofilament used for subcuticular suturing. Subcuticular suturing. Vicryl is polyglactin. It dissolves in 60 to 90 days. Vicryl is violet in color, dissolves in 60 to 90 days. These are non-absorbable sutures. Natural non-absorbable is silk. Synthetic non-absorbable are proline. The uses of proline are very important for the exam. I cannot promise whether I'll be able to share the PDF or not. It is best that you listen to it. If you want to click some pictures, take screenshots, you're more than welcome to do that. I will try to share the PDF, cannot promise that. So right now I would request all of you to just listen carefully. No, this is not going to be available on YouTube. If it's not very clear, please check the internet connection from your side. So the uses of proline, 3 uses of proline, which are extremely important: rectus sheath closure, vascular repair, and it is used as a mesh during hernia surgery. This is again an expected question in the exam. At what angle should the needle be inserted while suturing a wound for interrupted sutures? 90 degrees is correct. 90 degrees is the correct answer. Correct. So we enter at 90 degrees. Whenever we are suturing, we are going to enter at 90 degrees to the skin. That is correct. Another question which is frequently asked in the exam: what is the utility of the instrument shown in the image? Very commonly, this instrument is asked. Split thickness skin graft. And what is the instrument known as? Very good. Humby's knife. It is a Humby's knife, which is used for raising split thickness skin graft. It is a Humby's knife. That is correct. That is correct. And split thickness skin grafts, I want you to know, split thickness skin graft is epidermis plus some dermis. So split thickness skin grafts is epidermis plus some dermis, whereas full thickness skin grafts is epidermis plus entire dermis will be full thickness skin grafts. The most common site, donor site, is the anterolateral thigh. That is where you harvest the split thickness skin graft from. Foley's catheters. So Foley's catheters, बेटा अगर disturbance हो रही है आप अपने end पे check करिए internet. Majority लोगों को disturbance नहीं हो रही है. Which of the following is not true regarding Foley's catheters? 14 French is green in color. This is true. The best way to deal with the stuck Foley's is ultrasound guided puncture of the balloon. This is true. In a male patient, if the foreskin is not reposited, it can lead to phimosis, false. It can lead to paraphimosis. It can lead to paraphimosis and not phimosis. Three-way Foley's is used for clot retention. That is also correct. Okay. So it can lead to paraphimosis and not phimosis. Please remember that. So this is regarding Foley's. You can see, I just want you to remember that white is 12, green is 14, orange is 16, red is 18. I just want you to remember these four. These four you need to remember: 12, 14, 16, 18. And French in Foley's is outer circumference. Is outer circumference. Okay, please remember, French in Foley's is outer circumference. Very important question. Almost every year this question is asked in the exam. What is the appropriate time to give antibiotics before surgery? Correct. Very good. 30 minutes to 1 hour. Everyone knows this by now. Everyone knows this by now. 30 minutes to 1 hour is the best time. And prophylactic antibiotics should be given 30 minutes to 1 hour before surgery. Repeat dose in case of prolonged surgery after 4 hours. In case of prolonged surgery after 4 hours. And the best method to reduce wound infection is hand washing. Hand washing for whom? The patient or the surgeon? Absolutely. The doctor's hand washing. Correct. If you have to choose one between 30 minutes to 1 hour, you will choose 1 hour. Hair removal, clipping of hair. Correct. Nurse also. Clipping of hair should be done. No shaving should be done. Okay. What is the SSI rate, surgical site infection rate in a clean contaminated wound if prophylactic antibiotic prophylaxis is used? So this table is very important. Correct. It is 3% is the correct answer. 3% is the correct answer. And this table is very, very important. This is a table directly from Bailey, and you should know the risk of surgical site infection in each category. So clean wounds, it is 1 to 2%. In clean contaminated, if you use antibiotics, it is 3%. If you don't use it, it is 6 to 9%. In contaminated wounds, it is 6% if prophylaxis is used, and if prophylaxis is not used, it is 13 to 20%. It is 13 to 20%. Okay. Dirty wounds, it is 7% if antibiotic prophylaxis is used and 40% if antibiotic prophylaxis is not used. Cataract surgery is a clean surgery. Cataract surgery is a clean surgery. LSCS, cesarean, LSCS is clean contaminated. LSCS is clean contaminated. Okay. This is again a very important question. Hand hygiene, one question will be asked ever since Corona. Hand hygiene, hand washing questions are very important. Which of the following conditions the doctor should use a hand sanitizer before examining the patient, after examining the patient, after touching the patient's surroundings? When the hands are soiled, we should use soap and water. No, not all, not all. When the hands are soiled, we should use soap and water. Sanitizer will not be enough there. Okay. So these are the 5 moments of hand hygiene. You can expect a question from this diagram. These are the 5 moments of hand hygiene where you can use a sanitizer before touching, after touching, touching the patient's surroundings, before a procedure, and if you're exposed to the body fluids. In these 5 situations, a sanitizer can be used. But if you are visiting the toilet, or the hands are soiled, then in these 2 situations, we should use soap and water. In these 2 situations, we should use soap and water if we go to the toilet or if the hands are soiled. Please remember this. This is important. These are the correct steps of hand washing. They've been asked in the PG exams, not yet in the FMG exam, but I've told you hand hygiene is very important. Identify the clinical condition shown in the image. Correct. This is a carbuncle. Classic carbuncle is in the nape of the neck, and we make a cruciate incision. We make a cruciate incision. Sebaceous cyst, all of you should be able to identify sebaceous cyst. You should be able to identify sebaceous cyst has a punctum, and you should be able to identify with this punctum, you should be able to identify a sebaceous cyst. It requires excision. You can get multiple sebaceous cysts in the scrotum and scalp. So sebaceous cysts, all of you should know how to identify. A patient post-surgery develops low-grade fever on day 5, pain in the calf with pedal edema, most likely diagnosis. So a patient who is non-ambulatory, correct, DVT, deep venous thrombosis can occur. How will you confirm the diagnosis of DVT? What is the investigation of choice for DVT? That is correct. Doppler is the investigation of choice for DVT. That is absolutely right. Doppler is the investigation of choice for DVT. And you should know mechanical prophylaxis. These are pneumatic anti-DVT stockings. They've also been asked many times in the exam. These are pneumatic anti-DVT stockings, which you should be aware of. These two staplers have also been asked in the FMGE exam. Last year also they were asked. This is a circular stapler used for hemorrhoid surgery. This is a linear stapler. Linear stapler can be used for Zenker diverticulum surgery. This can be used for Zenker's diverticulum surgery. Correct. This first photo is anti-shock garment. The second one is pneumatic compression stockings, is pneumatic anti-DVT stockings. Correct. Linear stapler, Neha, you are right. It is used for Dolman's procedures in Zenker's diverticulum. Guys, I cannot promise you about the PDF, right? I cannot even tell you about YouTube. If the session is being recorded, I will try to put it on YouTube. Cannot promise it right now. So my request is that you listen to it. And then if it is available, we'll share the link with you. I cannot promise it. This is correct. This is the Babcock's forceps. This one is a Rampli sponge holder. So one instrument you always are asked, one simple straightforward instrument you're always asked in the exam. So you should know about these instruments also. This is a Rampli sponge holder. This one is a Langenbach retractor, a right angle retractor or a Langenbach retractor. This is a question mark shaped retractor or a Devers retractor, question mark shaped or a Devers retractor. And this one is a needle holder. Okay, this one is a needle holder. So all these basic instruments you should be aware of. This one is asked almost every year. Every year this instrument is asked. That is correct. Excellent. This is a monopolar cautery, the one which looks like a pencil. I've told you many times the one which looks like a pencil is a monopolar cautery. Bipolar cautery is going to be which looks like prongs. Which look like prongs is bipolar cautery. Okay, correct. Blue is cutting, yellow, blue is coagulation. No, sorry. Blue is coagulation. Blue is coagulation. Yellow is cutting, guys. Yellow is cutting. Blue is coagulation. This is a harmonic scalpel. This can coagulate without producing heat. It can coagulate without producing heat. This one was also asked in your December exam. Identify the image shown. It's a straightforward question, correct? Tracheostomy, very good. It is a tracheostomy, straightforward question. Shock, you will be asked two questions. Two questions from shock, one question from blood transfusions. So this is a very high yield topic. So we'll do some questions regarding this. You should know two questions from shock, one question from blood transfusion. Patient has hypotension and cold clammy skin. Most common cause? Hypovolemic shock. That is correct. That is correct. Hypovolemic shock. Please remember that the best indicator to determine amount of fluid required is pulmonary capillary wedge pressure is better than central venous pressure. This question has also been asked in the exam. Okay. So pulmonary capillary wedge in shock is urine output. So these 2 points also you should remember for the exam. Okay. A patient with cirrhosis and portal hypertension undergoes an upper GI endoscopy and is found to have varices. A few days later, she develops melena and has a repeated bleed. What is the cause for her bleeding? Correct. So variceal bleeding leading to hypovolemic shock. Leading to hypovolemic shock would be the cause of her bleeding. That is correct. Central venous pressure is increased in which shock? This is a very important question which you should know. Central venous. Correct. Cardiogenic shock. Now somebody is talking about MVOS. That is correct. MVOS is mixed venous oxygen saturation. This is mixed venous oxygen saturation. And mixed venous oxygen saturation is the best endpoint of fluid resuscitation, is the best endpoint of fluid resuscitation in hypovolemic shock. So if MVOS is given, you'll definitely mark MVOS over urine output. But if they are asking the best clinical indicator, then you're going to mark urine output. This is again a very important question. A 70 kg male comes to the emergency following a stab injury to the abdomen, and his pulse rate is 110, BP is 90/60. What percentage of blood volume has he lost? So always remember, when there is hypotension, the patient has at least class 3 shock. And if there is class 3 shock, you're going to remember it as the scoring of a tennis game. So class 3 would be close to 30 to 40. Class 3 would be close to 30 to 40%. So this is the summary for hypovolemic shock, which I want you to remember, that in class 2 shock, systolic BP will remain normal. There will be tachycardia, heart rate will be raised, but systolic BP remains normal. This is known as the compensated phase of hypovolemic shock. So if you read any question where there is tachycardia, but the systolic BP is normal, that means we are dealing with a class 2 shock. Class 3 shock would be when systolic BP falls for the first time. That is class 3 shock. And class 4 is when most of the parameters are unrecordable. That is class 4 shock. The capillary refill time is prolonged in all classes of in all types of shock except capillary refill time prolonged. Prolonged capillary refill means the hands will be cold, right? Hands and legs would be cold. So hands and legs would be cold in all except hypovolemic shock. We know hands and legs would be cold. Cardiogenic shock, we know hands and legs would be cold. Obstructive type is also a type of cardiogenic shock only. So the answer here is going to be septic shock. That is correct. Very good. Septic shock. Again, reactionary hemorrhage, primary hemorrhage, secondary hemorrhage is asked very commonly in your exam. Reactionary hemorrhage is within 4 to 24 hours of surgery. Very good. It is between 4 to 24 hours of surgery. So primary hemorrhage is during surgery. Reactionary is 4 to 24 hours. And secondary hemorrhage is one which occurs after a few days, and it is usually due to infection. Which one of the following is seen in massive blood transfusion? In massive blood transfusion, which one do you see? So because we are using citrate as the anticoagulant, metabolic alkalosis or citrate toxicity can be there. So metabolic alkalosis is the correct answer here. These are the complications of massive blood transfusion. Again, a very frequently asked question. There can be coagulopathy, hypocalcemia, hypothermia, hyperkalemia followed by hypokalemia, and metabolic alkalosis. So these are the complications of massive blood transfusion which you should know about. Identify the type of shock in a patient who has profuse bleeding and CVP is low. So CVP is low, less than 5. Correct. Hypovolemic shock is correct. Hypovolemic shock is correct. Okay. Which one of the following is not true regarding refeeding syndrome? It is associated. So refeeding syndrome is also frequently asked. It is associated with hypokalemia, hypophosphatemia, hypomagnesemia, and hypocalcemia. This is true. Thiamine supplementation reduces. This is also true. Strict monitoring of electrolytes should be done when TPN has been started. Cerebral edema and strokes are the leading cause of death. This is false. It is arrhythmias. Arrhythmias and CHF, which is the leading cause of death. Now, somebody asked about trolley. Trolley also, you should know the basics of trolley. So trolley can give rise to ARDS-like picture. And trolley, the full form is transfusion-related acute lung injury. Transfusion-related acute lung injury is trolley. It can give rise to ARDS type picture. And in trolley, it is usually secondary to FFP. Fresh frozen plasma infusion is the one which can give rise to trolley. So the typical history in the question would be that a patient gets blood transfusion and there is an ARDS-like picture. They can show you lungs with bilateral infiltration, and that is because of trolley. What is triage used for? Correct. Triage is used to classify priority of treatment. That is absolutely correct. Triage is used to classify priority of treatment. There is a 4 color-coded system. Red is high priority for transfer. Yellow is medium priority. Green is ambulatory patients. And black are dead or moribund patients. Okay. So you should know the color coding in triage. This is also frequently asked in the exam. A patient is brought with road traffic accident to the emergency room with tachycardia, hypotension, respiratory rate is raised, GCS is 7. What should be the next step in the management of this patient? Okay, some of you are answering fast. Why fast? They have not mentioned that this patient has abdominal trauma. So why will you do fast here? Here the GCS is 8 or less than 8. And we know if the GCS is 8 or less than 8, it is a sign of airway compromise. And always remember, it is always A, B, C, D. So A, if the patient is unable to speak, and if the GCS is less than 8, then first thing which we will do is airway intubation. So don't make a mistake in this. Always remember, primary survey is ABCD plus life-threatening injuries. And in ABCD, A, indications to achieve an airway. If the patient is unable to speak, GCS is 8 or less than 8, there is severe maxillofacial injury, or there is coma, then first get an airway in place. A patient presents to the emergency room after road traffic accident and he sustains blunt trauma to the abdomen. Which should be the initial step? Anup, so whenever we deal with a trauma patient, it is always ABCD, right? But if it's a cardiac cause, then we do CAB, right? So supposing the question says that you are working in an office space and one of your colleagues suddenly collapses, that is a CAB scenario. But in a trauma patient, because of accident, we always take care of ABCD. So what do we do here? We start resuscitation with IV crystalloids. And once you've done resuscitation, which investigation will you do in this patient? Blunt trauma, unstable blunt trauma. Correct. Now fast. Correct. Very good. Very good. Excellent. So always remember, now we are giving 1 liter of fluid instead of 2 liters. 1 liter of fluid instead of 2 liters is being given. GCS also is very important for your exam. GCS has been asked frequently. So you need to remember the GCS scoring. A patient who is admitted with road traffic accident is put on mechanical ventilation. He opens his eyes to verbal command. So E would be E3, verbal command. V, he's on ventilation. He cannot speak. So VNT, NT is non-testable. NT is non-testable. And M6. So E3, VNT, M6 will be the correct answer. You should know the GCS score. This GCS scoring you should remember for the exam. It is very, very important. Okay. Now, 2 scenarios, either cardiac tamponade will be asked or tension pneumothorax will be asked. So please, Either tension pneumothorax or cardiac tamponade, 100% it will be asked in the exam. You should know about it. Okay. An adult patient following a road traffic accident comes with subcutaneous emphysema. On auscultation, there is no air entry on the right side. Vitals are unstable. What will be your immediate management in these patients? Correct. So if we are suspecting, what are we suspecting here? Tension pneumothorax. And in tension pneumothorax, we are going to put in a wide bore needle in the fifth intercostal space. That is what we will do initially. That is correct. So please remember that needle decompression now is done in the fifth intercostal space, just anterior to the mid-axillary line. But in children, it is still done in the second intercostal space in the mid-clavicular line, right? In children, it is still done in the second intercostal space in the mid-clavicular line. In adults, it is fifth intercostal space, mid-axillary line where it is done. An adult patient comes with blunt trauma to the abdomen. He is complaining of left upper quadrant pain and vitals are unstable. What is the next step in the management? Correct. We'll carry out FAST. You should all know the full form of FAST. FAST full form has been asked in the exam. It is Focused Assessment Sonogram. It is Focused Assessment Sonogram in trauma. Focused Assessment Sonogram in trauma. This full form has been asked. And in FAST, the probe is kept at 4 places. We keep it in the epigastrium, then the right hypochondrium, then the left hypochondrium, and then the pelvis, right? E-FAST is extended FAST, where we even focus on the thoracic cavity. A patient after road traffic accident presented with pain in the abdomen. The resident examines and finds that there is tenderness in the left lumbar region. Vitals are stable. Vitals are stable. What investigation will you do here? Correct. Stable vitals, we will do CECT. Unstable vitals, we will do FAST. Very good. Excellent. But please remember, if you're given a case of penetrating trauma, if there is a patient with penetrating trauma, so there was a question in the NEET exam regarding penetrating trauma. If evisceration is there, if evisceration means bowel has come out, if peritoneum is breached, or if omentum is hanging out, then in these 3 situations, we straight away go for a laparotomy. There is no role of doing any investigations in these patients. Here we straight away do a laparotomy. And this was one of the questions asked in the NEET exam as well. A boy with a perineal injury comes to the emergency department. On examination, there is blood at the tip of the meatus and the boy has not passed urine. Bladder is not full. What is the next step in the management? So bladder is not full. There is blood at the tip of the meatus. So what are we suspecting if there's blood at the tip of the meatus? We suspect a urethral injury. Correct? We suspect a urethral injury. So in urethral injury, if the bladder is not full, we wait for the bladder to distend and give a trial of micturition. Okay, we wait for bladder to fill and give a trial of micturition. So remember this, please. If full bladder in suspected urethral trauma, then we do SPC, suprapubic catheterization. If bladder is not full and patient is in no discomfort, we wait for the bladder to fill and we give a trial of micturition. And the most common site of urethral trauma is the bulbar urethra. That has also been asked. The most common site is the bulbar urethra. Again, one guaranteed question. One I told you either tension pneumothorax will come or cardiac tamponade will come. One more guaranteed is head injury scenarios. So either EDH, SDH or diffuse axonal injury. One will definitely come in the exam. So these 3 scenarios should be clear. 50-year-old lady meets with a road traffic accident, traveling back from the office. Which of the following is most commonly associated with lucid interval? Correct. EDH is correct. Extradural hemorrhage occurs in young patients, high velocity impact, arterial in nature, middle meningeal artery is implicated. NCCT, you will get biconvex hemorrhage between the skull and the dura, and the management is going to be a burr hole or a craniotomy. Okay. So EDH, you will get a young patient, high velocity impact, subdural hematoma. The keywords which you should look out for are elderly patient, trivial trauma, and the patient will be normal for a few weeks before altered sensorium develops, correct? So usually they'll give a history of fall in the bathroom or a trivial fall in an elderly patient, and you will get a concavo-convex hemorrhage in SDH. The management remains the same. We have to carry out a craniotomy. The most severe is diffuse axonal injury. Here the patient will be in coma, but CT will be normal. So that is what will be given. The patient is in coma, GCS is not improving. This is another term which you should look out for. GCS is not improving. That is also a sign of diffuse axonal injury. NCCT is normal. And on MRI, you will see punctate hemorrhages in the gray and the white matter junction. Okay. So this is for diffuse axonal injury. You can see here, gets hit while crossing the road. GCS is 8/15. NCCT is normal. GCS has not improved. So this is diffuse axonal injury. This is the worst type of injury. Okay. This was another question which was asked in your December exam. A patient with head injury is admitted to the emergency room. Patient has increased intracranial pressure and low BP, right? And low BP. Which one of the following drugs will be useful in this patient? Mannitol. Okay. But you should know one thing, Cushing reflex. So Cushing reflex is seen in patients with head injury. Cushing reflex can be seen in patients with head injury. And Cushing's reflex is bradycardia, is brady plus hypertension. Brady plus hypertension. Okay. Correct. That is Cushing reflex. So this we've already discussed. Battle sign, very important. Battle sign was asked in your December exam. Battle sign is a sign of which cranial fossa fracture? So battle sign can be seen in patients with middle cranial fossa fractures, correct? Middle cranial fossa fractures. It is discoloration behind the mastoid process, and it is fracture of the petrous part of the temporal bone. These are black eyes or raccoon eyes, which can be seen in anterior cranial fossa fractures, A patient presents to the emergency room with the worst headache of life. Subarachnoid hemorrhage. Thunderclap headache or worst headache is subarachnoid hemorrhage. That is correct. A patient after road traffic accident has a blood pressure of 80/60. Fast scan is positive. What is the next step in the management of this patient? Correct. So if fast is positive, we straight away take up the patient for laparotomy. A young patient is brought to the emergency room with complaints of hypotension, distended neck veins, and muffled heart sounds. Patient passes away in the ER and an autopsy is performed. So this is cardiac tamponade. I told you tension pneumo versus cardiac tamponade. One question will be asked, and you should know Beck's triad. Beck's triad has also been asked many times. It is hypotension, raised JVP, muffled heart sounds. That is Beck's triad. Emergency management is needle pericardiocentesis. Definitive management is thoracotomy and creation of a pericardial window. Chronic smoker undergoes major surgery under general anesthesia. Suddenly the vitals become unstable and breath sounds are not heard. What is the most likely cause? I will share I will share the PDF. I have no problems, but it will not be a marked PDF. I mean, whatever I'm marking, the answers and all might not be there. Whatever I'm writing might not be there. Whatever is already written on the slides, I will try to share the PDF with you. So don't worry, but please listen to what I have to say. The topics which I'm mentioning, the questions which I'm showing you are very important. So please listen to it. I will try to share the PDF. Okay. No, this is not ARDS. This is not ARDS. This is a chronic smoker. So chronic smoker can have COPD and there will be blebs which will be there. And when blebs are there, these blebs can rupture and that can give rise to pneumothorax. That can give rise to pneumothorax. So this is not ARDS. Why will a patient undergoing surgery develop ARDS during surgery? Okay. So this is tension pneumothorax, which you should remember. Which of the following is an indication for laparotomy in a patient of penetrating abdominal trauma? This I've already told you, penetrating abdominal trauma. Presence of rebound tenderness, yes. Bile leaking, yes. Tag of momentum hanging out, yes. This is false. Superficial to peritoneum is false. This I've already told you the features. Which of the following is the most common organ injured in seatbelt syndrome? Mesentery is the correct answer. And these most commons are also frequently asked in the exam. Most commons in abdominal trauma. For blunt trauma, it is spleen. For penetrating, it is liver. Gunshot wound, it is small intestine. Seatbelt, it is mesentery. Deceleration is DJ flexure. And overall, it is spleen as well. What is the most common cause of mortality in trauma? Female driver. Why will it be different for a female driver? Why will the organs be different for a female driver? Doesn't a female driver have spleen? So head injury is the correct answer. That is correct. Head injury is the correct answer. Right. Which degree of burns has the patient sustained? Correct. This is second degree superficial. You can classically see the bleb which is there, and that is a classical sign of second degree burns. So first degree burns. So this also burns. Also, you get one question from the exam. First degree, they will heal spontaneously without scarring. Second degree burns. Second degree superficial burns. The classical finding is the presence of blister. Is the presence of a blister. And second degree deep burns can give rise to hypertrophic scars and keloids as well. These are third and fourth degree burns. Third degree burns involve subcutaneous tissue. Fourth degree burns involve the muscle layer. And you can see that they appear black and charred. They appear black and charred. What is the most? They are painless. Very good. They are painless. That is correct. The most important factor that predicts mortality in burns. The most important factor that predicts mortality in burns is the inhalational injury. That is correct. That is correct. Inhalational injury is correct. You should know the Wallace rule of 9 as well. There was one question in the NEET exam also, Wallace rule of 9. You should know that for your exam. No, Parkland's Mandar is not 4 into body weight. The new Parkland's formula is 2 into body weight into total body surface area. So the new formula is 2 into body weight. The Parkland formula has been updated. It is no longer 4. Please remember that. It is 2 into body weight, please. Only for electrical burns, it is 4. This is again a guaranteed question. Bed sore, one question is guaranteed asked in the exam. Bed sore is very important. This is a grade 4 bed sore. This was asked in the NEET exam as well. You should know this. The most common site of bed sore is ischium. Most common site is the ischium. And you require a pressure more than 30 millimeters of mercury. Faizan, these PG exam questions are also asked in FMGE exam, right? I'm not fond of showing you PG exam questions. All these have been asked in your exam as well. So it is better you study about them. No, we don't do a fasciotomy, Chand. We don't do a fasciotomy for a bed sore. Okay. So these are the 4 grades of bed sores, which are the same as burns, which you should remember. Okay. What is the best management for the wound shown in the image? This is an abrasion. This is an abrasion, and we clean and leave it open. You should also know about a VAC dressing. VAC dressing has also been asked in your exam. VAC is negative pressure dressing. VAC is negative pressure dressing. Minus 120 millimeters of mercury pressure is there. That is VAC or negative pressure dressing, which you should know about. This is also a very important question, whether you want to call it a pathology question or a surgery question. Which of the following is the normal order in which wound healing occurs? That is correct. Hemostatic, inflammatory, proliferative, and remodeling. Hemostatic, inflammatory, proliferative, and remodeling. That is the correct answer. Again, one question from hypertrophic scars or keloids. I have seen in the last 3 years, they've always asked. So you, after resecting a lipoma over the neck, patient develops an elevated scar with itching. The elevation is restricted to the region of the scar. Region of the scar, what is it? Hypertrophic scar. Very good. Hypertrophic scar. So keloid will grow beyond the boundary of the scar, whereas hypertrophic scars will remain within the boundary of the scar. These are the differences which you should know about. Keloid grows beyond the boundary and it does not settle with time and pressure, whereas hypertrophic scar settles with time and pressure. The sternal region is the most common site, and intralesional triamcinolone is the treatment of choice. Intralesional triamcinolone is the treatment of choice. That has also been asked. What is this? This is a keloid, correct. This image has been asked. This is a keloid, correct. Again, a very important question. A patient receives a renal transplant from an identical twin. Identical twin, isograft. It is isograft. That is correct. So these definitions you should know. Auto is from the same person. Iso is from identical twins. Allo is same species. And xeno is different species. Now, breast also 2 or 3 questions are asked. 2 questions will be image-based questions. 1 is usually a text-based question. Which of the following breast cancers has the best prognosis? It is luminal A has the best prognosis. It is also the most common, and basal has worse prognosis. Basal has worse prognosis. That is correct. So luminal A is ER/PR positive, HER2/neu negative is luminal A, and luminal A has the best prognosis. It is the most common as well. Basal has the worst prognosis and it is triple negative. So these are the only 2 which I want you to remember for the exam. These are the ones which will be asked. So you should know these 2. A 35-year-old lady came with a single mobile lump in the right breast, measuring 2 into 2 centimeters. It was firm in consistency. Family history of breast cancer is positive. So what is the diagnosis? First of all, please tell me the diagnosis. Fibroadenoma. Very good. Mobile lump, fibroadenoma. Excision would be done. Very good. Excision would be done. So this is how we do excision. These days I do VAB, which is scarless breast surgery, can also be done in these patients. 3 days after delivery, 25-year-old lady comes with a tender fluctuant mass. On ultrasound, pus is present, collection is present. What do we do? Correct, incision and drainage. If pus is there, we will do incision and drainage. This is what a breast abscess looks like. Images have been asked very frequently regarding breast abscess. So you should know breast abscess, it is Staphylococcus aureus. Staph aureus is the most common organism. And if pus is present, you either aspirate or you have to drain. You should be able to identify PDO. PDO is peau d'orange. It is peau d'orange. And why does peau d'orange or orange peel appearance occur? This is inflammatory cancer. And why does this appearance occur? This has been asked. Why does this appearance occur? Correct. Because of subdermal lymphatics. Involvement of subdermal lymphatics. Very good. Because of involvement of subdermal lymphatics, this is why it occurs. This is another question which has been asked in the exam. A 45-year-old lady comes with a rapidly enlarging breast lump, which is firm, mobile on examination and has a bosselated surface. This is a phyloids tumor. Correct. Phyloids tumor. This is what a phyloids tumor looks like. And phyloids tumor, there will be, correct, leaf-like, rapid increase in size will be there. Rapidly progressive. It will be rapidly progressive. Right. Surgery here is going to be we either do lumpectomy or we do a mastectomy in these patients. A 55-year-old lady, postmenopausal patient, comes with a breast lump which measures 6 into 4 centimeters. There is a single mobile lymph node, no distant metastasis. What is the management? This is cancer and it is 6 into 4 centimeters. So this is LABC. You should know the definition of LABC, locally advanced breast cancer. Definition you should know. It is very important for the exam. Locally advanced breast cancer or LABC is T3N1M0, NET4, NEN2, NEN3 with M0. And in all these patients, we will give neoadjuvant chemotherapy first. Neoadjuvant chemotherapy followed by mastectomy followed by radiotherapy. Now, please remember staging. Staging, I just want you to remember for 2 cancers, breast and oral cancer. So just 2 cancers, I want you to remember the staging, breast and oral cancer. Please revise the staging. So this is neoadjuvant chemotherapy followed by modified radical mastectomy. This you should know for your exam. I'm talking about surgery, gynae staging. You should ask the gynae faculty, please. Correct. This is P4B. It is skin involvement. We've already discussed this. This also we have discussed. Staging, I've told you, breast and oral cavity, oral cancer staging, you should know. A patient with breast cancer undergoes a repeat biopsy and signet ring cells are seen on biopsy. Which of the following is this lesion is the patient suffering from? Correct. Wherever you see signet ring cells, it will be lobular cancer. Signet ring cells, it will be lobular cancer. You should know about this. And the histopathological slide has also been asked. This is known as a single file or an Indian file pattern. This is a single file or an Indian file pattern, which you should know about. This has also been asked in the exam. Again, we've already discussed this. This is a breast abscess. We've already spoken about this as well. This was another question which was asked in your December exam. A patient underwent surgery for breast cancer 4 months back. So the time duration is very important. Just 4 months has been the time since surgery. She now comes with a painless swelling involving the arm. Okay, painless swelling involving the arm. What is the most likely diagnosis? So it will be lymphedema. With 4 months history, it will only be lymphedema. It will not be lymphangiosarcoma. Please remember this. Lymphedema is one of the complications of breast surgery, right? Most common cause of upper limb lymphedema is post-mastectomy lymphedema, right? Is post-mastectomy lymphedema. It will develop few months after surgery. More chances with axillary lymph node dissection as compared to sentinel lymph node biopsy. I'm coming to nerve injury. Very good question you're asking. I'm coming to nerve injuries. Nerve injuries are being asked very frequently these days. I'm coming to that. Before that, you should know if it's a long-standing lymphedema. If it is long-standing lymphedema more than 8 to 10 years, so time is important, 8 to 10 years, then it is lymphangiosarcoma or Stewart-Treves syndrome. So there are two separate questions. I don't want you to get confused, please. Okay. These are local recurrences following breast cancer surgery, and this local recurrence is known as cancer in cuirass. This is known as cancer in cuirass. These drains, you should remember, this is a Romovac drain, which is a closed suction drain. This is a Romovac closed suction drain, which you should remember. It has been asked in very many exams. You should know about this. This is a smaller version of that drain known as Minivac. This one is used for abdominal surgeries. This is a Jackson-Pratt or a JP drain. Jackson-Pratt is used for abdominal surgeries. This is also a closed drain. So we've already done. Yes, a patient following breast cancer surgery comes to the clinic with an abnormality shown in the image. Which nerve has been injured in this patient? Which nerve has been injured? Correct. It is long thoracic nerve, which is due to winging of scapula. Very good. Which gives rise to winging of scapula. So these nerve injuries are important for your exam. So you should know here these nerve injuries. Most commonly injured nerve is the intercostobrachial nerve, ICBN, and it will give rise to sensory abnormalities in the axillary region. It will give rise to sensory abnormalities in the axillary region. Long thoracic nerve, if it is injured, it will give rise to winging of scapula. Thoracodorsal nerve, latissimus dorsi, and yes, Shubham, most common is intercostobrachial. Most common is intercostobrachial. Serratus anterior would be winging of scapula, that is long thoracic nerve, Karthik. Okay. This is a Mondor's cord. This also you should know about. This is Mondor's disease. This is a cord-like swelling which can be seen. This is thrombophlebitis of the chest veins. This is thrombophlebitis of chest veins. Okay, moving on to thyroid now. Thyroid also 2 or 3 questions are asked. One question is usually asked regarding the investigations. One question is asked regarding surgical complications. Okay. So one question is usually from investigation. So you have a 39-year-old lady. She comes with features of heat intolerance, weight loss. On examination, the right lobe of thyroid. On examination, the right lobe of thyroid reveals a 2 into 2 centimeter swelling. TSH is low. What is the next step in the management of this patient? So this patient has features of hypothyroidism or hyperthyroidism? Hyper, correct. Hyper and low TSH. What will we do first? We will do thyroid scan. We will do a thyroid scan in these patients. Okay. So this thyroid scan, what does it depict? Correct. This is Plummer's disease. Plummer's disease or toxic nodular goiter. You can see multiple hot nodules. This is Plummer's disease or toxic nodular goiter. In Zuska's disease, you will prefer Hatfield's procedure. Whomsoever asked that question, in Zuska's, you will prefer. Yes, in Zuska's, we'll do Hatfield's procedure. So this is a normal thyroid scan. What are the abnormalities in a thyroid scan you should know about? So you should know about a cold nodule and a hot nodule. Cold nodule, you can see that the entire gland is taking up the contrast, but this one particular nodule is not taking up any contrast or any iodine. This is a cold nodule or a non-functioning nodule. Correct, non-functioning nodule. and cold nodule have higher risk of cancer. 20% can be cancerous. Hot nodule, this is a hot nodule or a hyper-functioning nodule. This is a solitary toxic nodule. Okay, so hot and cold, I've told you. This one is toxic nodular goiter, where you can see multiple hot nodules. This is toxic nodular goiter or plumber's disease. Okay, I will just tell you, Ishan, let me just tell you about thyroid investigations. Just 1 second, I'll tell you about thyroid investigations. How do we go? So please remember, the first investigation in thyroid is always thyroid function test. That is the first investigation in thyroid. The investigation of choice in thyroid is FNAC, is fine needle aspiration cytology. If TSH is low and hyperthyroid features are there, then we will do a thyroid scan. This we've already discussed. Which isotope is used for thyroid cancer management? Iodine 131. That is correct. 131, and it acts via which rays? Beta rays. No, guys, beta rays. Acts via beta rays. And half-life is 7 to 8 days. Very important slide. This is also frequently asked. So either papillary carcinoma thyroid slide is asked or medullary carcinoma thyroid slide is asked. Papillary carcinoma, you will see orphan aniide nuclei, or you will see samoma bodies. So papillary thyroid cancer and medullary thyroid cancer slides are very important. So you can see orphan aniide nuclei here, and this is papillary thyroid cancer. This is papillary thyroid cancer, which is the most common thyroid cancer, and it has the best prognosis. Again, you can see a better slide of papillary carcinoma thyroid, where you can see orphan aniide nuclei. Medullary thyroid cancer, I don't have the slide, but medullary thyroid cancer, you will see amyloid-rich stroma. In medullary thyroid cancer, you will see amyloid-rich stroma. So this amyloid will be visualized as pinkish material. It will be visualized as pinkish material. So they will give you a question that an FNAC is done, and you will see this pinkish material on a slide. Which cancer are you dealing with? You're dealing with medullary carcinoma thyroid, and calcitonin, yes, is a tumor marker for medullary carcinoma thyroid. A patient with a thyroid disorder comes with high TSH and high anti-TPO antibodies, anti-TPO, anti-thyroid peroxidase antibodies, Hashimoto's thyroiditis, correct. So Hashimoto's thyroiditis is the most common type of thyroiditis. It is autoimmune. And here you are going to get antibodies against the thyroglobin, thyroid receptor, and thyroid peroxidase enzyme. A patient comes with diffuse goiter and has raised T3 and T4. Diffuse goiter has raised T3 and T4. What is the diagnosis? Graves' disease. Very good. Graves' disease is correct. So, like I told you, one question will be from complications of thyroid surgery. So a patient undergoes a thyroidectomy, and post the surgery, the anesthetist is unable to extubate her due to persistent cyanosis and airway obstruction. Most probable cause, please. Correct. Bilateral recurrent laryngeal nerve injury. Very good. Bilateral recurrent laryngeal nerve injury. So this is a very important slide, and I want you to remember this slide for your exam. External laryngeal nerve injury is not life-threatening. External is not life-threatening. It will just lead to hoarseness. Patient won't be able to sing in the bathroom, okay? Patient will not be able to sing at a high pitch because of injury to the cricothyroid. Yes, correct. External laryngeal nerve injury is more common than recurrent laryngeal nerve injury. Dave, that is absolutely right. Unilateral recurrent laryngeal nerve injury, hoarseness can be there. Bilateral recurrent laryngeal nerve injury, there can be airway obstruction and stridor can be there in these patients. Very good. Altaf, correct. External laryngeal nerve injury is more common, but mostly undetected. Excellent. These are two signs which are seen in hypoparathyroidism or hypocalcemia. Schwastic sign is when you get a carpopedal spasm, and Trousseau sign is when you get twitching of the facial muscles. This was again asked in your exam. Again, a very important question. Correct. This is a sesame B scan, right? The best is technetium 99 sesame B scan. Technetium 99 sesame B scan is used for localizing parathyroid tissue. The incision which is used for neck dissection is modified Schobinger's incision. Modified Blair's is known as lazy S. This is used for parotidectomy. Stewart's incision is used for MRM. ELN injury, nothing. We just give steroids to see if that is getting better or not. Otherwise, nothing is to be done. Okay. 25-year-old presents with hypertension with profuse sweating and headache. Which of the following investigations should be ordered in these patients? So last time also there was a question from pheochromocytoma in your exams. You should know about pheochromocytomas, urinary VMA and metanephrines. That is correct. So pheochromocytoma, remember please, headache is the most common symptom. Hypertension is the most common sign. It is mostly episodic. The screening test is 24-hour urinary VMA or metanephrines. Most sensitive is plasma-free metanephrines. Okay. You get a tan brown cut surface. MRI is the investigation of choice, and on MRI you will get a light bulb sign. MRI you will get light bulb sign. And extraadrenal pheochromocytoma, you will do a gallium dotatate scan. This is the light bulb sign which you can see in these patients. This was also asked in your exam. You have a 60-year-old male who complains of cold intolerance, lethargy and weakness. On thyroid function test, TSH is raised, TSH is raised, most appropriate management. So we always start from the least possible dose, that is 25 micrograms, and we gradually increase the dose. That is what we do. We start from a lower dose and we gradually increase the dose. Correct. It looks as if you people are very well prepared. You're answering all the questions very well. So that is good. Which of the following is not true regarding the swelling shown in the image? What is the swelling? It is a ranula. Very good. It is a mucus extravasations. That is true. It is brilliantly transilluminant. It is true. Treatment is marsupialization. That is also true. It is related to submandibular gland. That is false. It is related to the sublingual gland. So ranula is a mucus extravasation cyst. It is fluctuant and brilliantly transilluminant. Incision and drainage should not be done in these patients. Marsupialization should be done, and it involves the sublingual gland. We can do excision also. Navneet, we can even do excision. So either excision or marsupialization can be done. Okay. Plunging is both submandibular and sublingual. Soham, that is absolutely right. Recurrence and excision would be less. Karishma, recurrence and excision would be less. And what is the most common nerve injured when we are doing granular surgery? Lingual nerve. Very good. Most common nerve injured is lingual. Excellent. Lingual nerve. That is correct. A male patient develops paralysis after parotid surgery. Injury to which structure is most likely responsible? The mandibular branch of the facial nerve. That is correct. So mandibular branch supplies the lower lip. Mandibular branch supplies the lower lip, and that is also known as the marginal mandibular nerve. One more question. A patient undergoes parotid surgery and there is anesthesia over the beard area. He is having no sensations over the beard area. Which nerve? Which nerve? Greater auricular. Very good. Greater auricular nerve. No sensation over the beard area. Greater auricular nerve. Very good. That's correct. And Fraze syndrome. Fraze syndrome is gustatory sweating. Which nerve? Auriculotemporal. Very good. Auriculotemporal. Excellent, guys. Good. So again, one question from oral cancer is definitely asked in the exam, whether it is regarding the risk factors or it is regarding oral cancer diagnosis or staging itself. You should know about this. This one is a whitish patch and this is known as leukoplakia, right? This one is leukoplakia, whereas this is candidiasis. And you can see the difference that in candidiasis, you have a reddish border around the patch. In candidiasis, you have a reddish border around the patch and you can rub it off. Leukoplakia, you can't rub it off. This is erythroplakia. This is a red patch. Erythro means red. This is a red patch. Yes, leukoplakia can be seen in tobacco eaters. This is oral submucous fibrosis. The patient is unable to open his mouth. There is submucous fibrosis. This is betel nut hypersensitivity. Very good. Correct. Most common site of oral cancer overall is the oral cavity. It is the oral cavity. That is correct. And in India, it is the buccal mucosa. In the world, it is the lateral border of tongue. RMT is retromolar trigone. RMT is retromolar trigone. Retromolar trigone is a triangular space which is present behind the molars, and there you can miss it out. Yes, and in India, buccal mucosa. All over the world, it is the lateral border of tongue. Okay, vascular system. Vascular, again, is important. Two questions from vascular surgery are usually asked. One is regarding arterial, one is regarding venous. That is how the mix is. They ask you questions. Male patient coming with smoking, blackening of the index finger. What is the most likely? Berger's disease. Very good. Berger's disease is linked with smoking. 50-year-old lady underwent orthopedic surgery of the lower limb for which she was bedridden for 3 days. She develops breathlessness and suddenly was brought to the ER. Most likely diagnosis, please. Why fat embolism, guys? Why fat embolism? She underwent a hip replacement or a knee replacement. Why fat embolism? There wasn't any fracture. Just because orthopedic surgery is given, why are you going towards fat embolism? So fat embolism, there will be a history of long bone fracture, right? It will be 48 to 72 hours later. There will be petechial hemorrhages which will be seen. None of that has been mentioned here. The patient is bedridden. Here the patient is bedridden. We discussed earlier also, bedridden will be DVT. I hope this is clear. Mohil, I know these are confusing, which is why I'm trying to clarify. The key words which you need to look out in fat embolism will be petechial hemorrhages, long bone fracture, and usually 48 to 72 hours. They'll give that in the axilla, there are petechial hemorrhages. Here, nothing of that sort is mentioned. Here, the patient is bedridden, so DVT. This question, Divya, question with air embolism will be patient undergoing thyroid surgery and the patient suddenly collapses. That is a typical history of air embolism. Or hysteroscopy is being done by gynecologists, patient suddenly collapses. Air embolism. So the CEAP grading you should know about. The CEAP grading is very, very important for the exam. It's been asked in your exam also, and especially these skin changes, pigmentation, lipodermatosclerosis, coronaphlebectasia, all these you should know. These are thread veins. These are thread veins which are less than 1 millimeter. This is corona phlebitis or malleolar flare. Corona phlebitis or malleolar flare is when you have fan-shaped pattern of telangiectasic veins which are less than 1 millimeter. That is known as corona phlebitis or malleolar flare. This is lipodermatosclerosis. This has also been asked in your exam. This is lipodermatosclerosis. You get an inverted champagne bottle appearance. You get inverted champagne bottle appearance. Lyric syndrome, very, very frequently asked. In NEET PG it is asked, in FMGE it is asked. All of you should know. Lyric syndrome is when there is a block at the aortic bifurcation. Aortic bifurcation block. You should know that whenever there is an aortic bifurcation block, these patients are going to come with gluteal claudication. Gluteal pain, gluteal claudication, that is the earliest feature of lyric syndrome. And there will be, these patients can also have impotence. Very important question. A patient is undergoing CABG. Saphenous vein is harvested for grafting. Which nerve can be injured when they are harvesting the saphenous vein? So saphenous vein, great saphenous vein is linked with the saphenous nerve. The great saphenous vein is linked with the saphenous nerve. So these nerve-related questions, you will definitely be asked. At least 2 questions regarding nerve-related complications will be asked in surgery. So I've told you for breast surgery, thyroid surgery, oral surgery, and now for varicose vein surgery also. Sural nerve, correct, is with the short saphenous vein. Sural nerve is with the short saphenous vein, that is correct. This is a repeat question. This was asked in your exam in the first part of 2021. This is primary Raynaud's. Raynaud's, you will get white, blue, red. This is primary Raynaud's. Why is this primary Raynaud's? Because primary is more common and not linked with any autoimmune diseases. Not linked with any autoimmune diseases. That is primary Raynaud's. A patient had burns 10 years back and now presents with ulceration over the burnt area. What is the diagnosis? Very good. Marjolins. Marjolins is usually which type of cancer? Marjolins is usually which type of cancer? SCC. Very good. SCC. Squamous cell cancer. Image has been asked. Image of Marjolins ulcer. You should know. You should know the image of Marjolins ulcer. This I've told you. Patient with a history of smoking comes with cramping gluteal pain after walking 500 meters. Which vessel is implicated? Arterial disease with aortoiliac involvement. That is correct. This I've told you, lyric syndrome. I've explained to you. One question from skin is asked. So either they will ask Marjolin's ulcer or a sebaceous cyst is asked or carbuncle is asked. Phonia's gangrene also you should be able to identify. Phonia's gangrene can be asked, or they can ask a basal cell carcinoma. Basal cell carcinoma is usually above the line joining the angle of the mouth to the ear lobule. Right? So basal cell cancer or rodent ulcer above the line joining angle of mouth to ear lobule. It is locally invasive and it rarely gives rise to metastasis. A lady with atrial fibrillation presents with sudden occlusion of the artery. Which of the following signs has a poor prognosis? So paralysis, correct? If paralysis develops, that is poor prognosis. Paralysis develops, that's a poor prognosis. A patient undergoes prolonged surgery and is bedridden for a long period. Surgeon examines her lower limb and is found to have Homan sign positive. What is your diagnosis? Homan sign positive, DVT, correct, DVT. So 2 signs can be done and you should know it is mostly unilateral Patient can come with pain or limb edema. Homans and Moses are the two signs. Homans is dorsiflexion of the foot. Moses is squeezing of the calf. And the investigation of choice has also been asked. It is a duplex scan. Which type of ulcer is this? Correct. It is a venous ulcer which is present over the medial malleolus or the gaiter area. Medial malleolus or the gaiter area. That is correct. Prophylactic CNS radiation is given following which cancer? Carcinoma lung. Correct. Carcinoma lung. This was asked last year in your exam. There's high incidence of brain metastasis in carcinoma lung. That is why patients with stage 2 and stage 3 can be given prophylactic CNS radiation. Which one of the following is the investigation of choice for pulmonary thromboembolism? The investigation of choice is CT angiography, but the gold standard investigation is pulmonary angiography. Okay, so there are two different questions. Here I'm asking investigation of choice. So here it is going to be CT angiography. Here it is going to be CT angiography. What is the cause of cannonball metastasis on the chest X-ray? Lung metastasis. Very good. Lung metastasis. What is the preferred treatment for the condition shown in the image? What is the condition? What is the condition, guys? Dermoid cyst. Very good. Dermoid cyst. Why are you saying incision and drainage in dermoid cyst? Why incision and drainage in dermoid cyst? You have to do surgery. Excision has to be done. No incision and drainage, guys. No incision and drainage. Correct. We rule out intracranial spread, but we carry out surgery then. Okay. So these were the details. These is where I've covered general surgery, endocrine surgery, vascular surgery, and trauma. I've covered. I will be posting one video on the YouTube channel regarding GIT and urology. I will post it by tomorrow or latest by day after. So please watch that video on my YouTube channel. I will post that video as well. Okay, so please go through these questions. I will share the PDF with you. Please revise them. And on my YouTube channel are the last year's December 2021 surgery recall. Definitely watch that. For all the subjects, last year's recalls you should definitely watch. All the best. I think so you guys are very well prepared. Last week, just do recalls. Last 2-year recalls you have to do, and you will be in a very good position to crack the exam. All the best, and I'm waiting to hear great stories from all of you once you pass your exam. All the best, guys.